Now, welcome everybody. This is the next portion of the lecture continuing, and we'll be going on to the continuation portion of this particular subject. Please stay tuned. Right, so we were on the video on monoclonal antibodies. We're on to the subject matter proper now. I think you've seen the video. Now about monoclonal antibodies, we'd like to know more. Let's check that. Excuse me. Now, about monoclonal antibodies. How do monoclonal antibodies work against cancer? Which cancers are treated with monoclonal antibodies? What are the side effects of monoclonal antibodies? Now, this picture, illustration shows that some monoclonal antibodies mock cancer cells so that the immune system will better recognize and destroy them. Credit goes to National Cancer Institute for this illustration. And on to the question, how do monoclonal antibodies work against cancer? Monoclonal antibodies are immune system proteins that are created in the lab. Antibodies are produced naturally by a body and help the immune system recognize germs that cause disease, such as bacteria, viruses, and mark them for destruction. Like your body's own antibodies, monoclonal antibodies recognize specific targets. Many monoclonal antibodies are used to treat cancer. They are a targeted cancer therapy, which means they are designed to interact with specific targets. Learn more about targeted therapy. I think we've already listened to that. I've given you a lecture on that. In case you need a reference, you can always go back to the lectures in this series. Right? Some monoclonal antibodies are also immunotherapy because they help turn the immune system. Right, some monoclonal antibodies are also immunotherapy because they help turn the immune system against cancer. For example, some monoclonal antibodies mock cancer cells so that the immune system will better recognize and destroy them. An example is rituximab, which binds to a protein called CD20 on B cells, and some types of cancer cells causing the immune system to kill them. B cells are a type of white blood cell. Other monoclonal antibodies bring T cells close to cancer cells, helping the immune cells kill the cancer cells. An example is blinatumomab, or Blink-2 is the trade name. As a blinatumomab is the generic name, and Blincyto, it is the brand name, is a registered brand name, which binds to both CD19, a protein found on the surface of leukemia cells, and CD3, a protein on the surface of T cells. This process helps the T cells get close enough to the leukemia cells to respond to and kill them. Now you have a picture of monoclonal antibodies bringing T cells close to cancer cells, T cell, and the cancer cell, monoclonal antibodies bring them close, helping them to kill cancer cells. Credit goes to the National Cancer Institute for this illustration. Which cancers are treated with monoclonal antibodies? Many monoclonal antibodies have been approved to treat a wide variety of cancers. To learn more about specific treatments to your cancer, see the PDQ adult cancer treatment summaries and childhood cancer treatment summaries. Right? The adult cancer treatment summaries, I think we've seen it, the PDQ. Let's go to the childhood cancer treatment summaries. We have an alphabetic list of PDQ, brand and pediatric cancer treatment summaries, right? And these are the various treatments for the patient and health professionals. So if I were to say all this, let's just go take an example and see how it's being explained. Now you go to acute lymphoblastic leukemia for childhood, from the patient's point of view and health professional point of view. Okay, we'll go to the health professional point of view. It's shown this way: how the childhood acute lymphoblastic leukemia treatment, PDQ, health professional version, right? Patient version and professional version. On this page, you have general information about childhood acute lymphoblastic leukemia. You have the World Health Organization classification for childhood ALL, cytogenetics or genomics of childhood ALL, risk-based treatment assignments, right? And treatment options overview for childhood of ALL, special considerations of treatment of children with ALL, treatment of newly diagnosed childhood ALL, central nervous system, directed therapy for childhood ALL, post-induction treatment for specific ALL subgroups, treatment of relapsed childhood ALL, latest updates to the summary at 08/28/2024 about this PDQ summary. This is what comes for the professional version. And if you were to look at the patient version, this is the patient version. We're going to that now, right? And it shows likewise child with acute lymphoblastic leukemia PDQ patient version. On this page, we sees what is child with acute lymphoblastic leukemia. It's for the patient's perspective, trying to understand what it is about, causes and risk factors for childhood acute lymphoblastic leukemia, genetic counseling, symptoms of childhood ALL, tests to diagnose ALL, childhood ALL, getting a second opinion, risk groups of childhood ALL, the types of treatment options, prognostic factors, side effects and late effects, follow-up care, coping with your child's cancer, related resources, and about this PDQ summary, right? So that's it about the versions. And we get to see the study part of it, all right? And that was the reference. Now we're going back. So what are the side effects of monoclonal antibodies? With regard to those treatment versions, okay, if you need any explanations, you could always come back to the comment section, the section, and please mention it there, and I'll be more than glad to give you an explanation on any and all aspects of these treatment, the cancer treatment summaries for child and, adults, right? Now, monoclonal antibodies can cause side effects which can differ from person to person. The ones you may have and how they may make you feel will depend on many factors, such as how healthy you are before treatment, your type of cancer, how advanced it is, the type of monoclonal antibody you're receiving, and the dose. The doctors and nurses cannot know for sure when or if side effects will occur or how serious they will be. So it is important to know which signs to look for and what to do if you start to have problems, right? Like most types of immunotherapy, monoclonal antibodies can cause skin reactions or at the needle site and flu-like symptoms. Needle site reactions include pain, swelling, soreness, redness, itchiness, rash. Learn more about skin changes caused by cancer treatment, flu-like symptoms, chills, fatigue, fever, muscle aches and pains, nausea, vomiting, and diarrhea. So learn more about flu-like symptoms caused by cancer treatment. So let's learn more about skin changes caused by cancer treatment. We'll switch on to that now. Now, skin and nail changes during cancer treatment. Cancer treatments may cause skin and nail changes. Talk with your healthcare team to learn what side effects your treatment may cause. While skin problems caused by radiation therapy and chemotherapy are often mild, they may be more severe if you are receiving a stem cell transplant, targeted therapy, or immunotherapy. Let your healthcare team know if you notice any skin changes so they can be treated properly. And when this picture has to do with when cancer treatment causes skin and nail problems, these are creams. There are creams and lotions that can help your skin to feel better. Credit is from iStock, right, for this picture. Some radiation therapy can cause the skin or part of the body receiving radiation to become dry and peel, itch, called pruritus, and turn red or darker. Your skin may look sunburned or become swollen or puffy. You may develop sores that become painful, wet, and infected. This is called a moist reaction. Some types of chemotherapy can cause your skin to become itchy, dry, red, or darker, or peel. You may develop a minor rash or sunburn easily. This is called photosensitivity. Some people also have skin pigmentation changes. Your nails may be dark and cracked, and your cuticles may hurt if you received radiation therapy in the past. The area of skin where you receive radiation may become red, blister, peel, or hurt. This is called a radiation recall. Signs of an allergic response to chemotherapy may include a sudden or severe rash or hives or a burning sensation. Stem cell transplants can cause graft versus host disease GVHD, which may cause skin problems such as rash, blisters, or thickening of the skin. Some types of immunotherapy can cause a severe and sometimes extensive rash. Your skin may be dry or blister. Some types of targeted therapy may cause dry skin or rash and nail problems. If you develop a rash, it is important to talk with your doctor before stopping targeted therapy. You can ask your healthcare team about skin and rash nail changes and what skin and nail changes might I have based on the cancer treatment I'm receiving, which symptoms can be managed at home, which symptoms need urgent medical care. If you have a severe, extensive, blistering or painful rash and are receiving immunotherapy, call your doctor to get their advice. It's especially important to call about rashes that involve the eyes or a mucous membrane, such as your mouth, caused by immunotherapy. Make note of all your problems or problems you should call your healthcare team about. Skin changes are AIIMS&NEET, acne-formed eruptions, bed sores or pressure ulcers, blisters, burning of skin, pain, dry skin, hand-foot syndrome, palmar, plantar erythrodysesthesia. Let me repronounce that for you. Plantar erythrodysesthesia. Hyperpigmentation, darker areas of skin, tongue and joints. Hyperpigmentation, patches of skin that are lighter. Itchy skin is pruritus. Keratoacanthoma, dome-shaped skin growth, peeling, flaky or crusty skin, photosensitivity, sunburn easily. Rash, red or darkened skin, sores that are painful, swollen skin. Nail changes would be cracked nails, cuticles that are swollen and or painful. Nail infections, acute paronychia, and yellow nails. Ways to prevent or manage mild skin and nail changes during cancer treatment. Talk with your healthcare team to learn if you should manage these problems at home. Depending upon the treatment you are receiving, your healthcare team may also advise you to take these steps. Use only recommended skin products. Use mild soaps that are gentle on your skin. Ask your nurse to recommend specific skin products. If you are receiving radiation therapy, ask about skin products such as powder or antiperspirant that you should avoid using during or before treatment. Prevent infection. Radiation therapy can cause skin, the treatment area to peel, become painful and wet. Most often this happens in areas where the skin folds, such as around your ears, breast, or bottom. Try to keep the area clean and dry so it does not become infected. Your nurse will talk with you about how to clean the area and may prescribe special dressings that you can apply to the area and or antibiotics. Moisturize your skin. Use recommended creams or lotions to prevent your skin from becoming dry and itchy. Irritated skin can become infected. Ask your special creams or ointments for severely dry, itchy, or painful skin. Protect your skin. Use sunscreens and protective lip balm. Wear a loose-fitting long-sleeve shirt, pants, and a hat with a wide brim when outdoors to prevent sunburn. If you are receiving radiation therapy, don't use heating pads, ice packs, or bandages on the treatment area. You may want to shave less often and use an electric razor or stop shaving if your skin is tender and sore. Prevent or treat dry skin, itchy skin. Avoid products that list alcohol or fragrance as an ingredient, since they can dry or irritate your skin. Your nurse may suggest you add colloidal oatmeal to your baths, as it can reduce itching. Take short showers or baths in lukewarm, not hot water. Put on skin cream or ointment that is recommended by your nurse after drying off from a shower. But while your skin is still a little damp, apply a cool washcloth or ice to dry itchy skin. Prevent or treat minor nail problems. Keep your nails clean and cut short to avoid accidentally tearing them. Protect your hands and nails by wearing gloves when you wash these dishes or clean the house, for examples. Avoid getting manicures and pedicures. Don't wear tight-fitting shoes. Ask your nurse to recommend products that can be used to treat nail problems. learn about treatments for irritating or painful skin rashes. Sometimes skin problems need medical treatment. Your rash may be treated with a medicated cream, topical corticosteroids, or with medicine that you take as a pill. Oral corticosteroids or antibiotics. Talking with your healthcare team about skin and nail changes. Prepare for your visit by making a list of questions to ask. Consider adding these questions to your list. What skin and nail related side effects are common for the type of treatment I'm receiving? Are the steps that I can take to prevent any of these problems? What problems should I call you about? Are there any problems that need urgent medical care? What might these problems start? When might these problems start? How long might they last? What brands of soap and lotion would you advise me to use on my skin, on my nails? Are there skin and nail products I should avoid? Should I see a dermatologist so I can learn more about how to prevent or manage skin problems? Listen to tips on how to manage mild skin changes caused by cancer treatments such as radiation therapy, right? Type MP3 time 220 size 220M, view the transcript. So here we're listening to that.
What to do about mild skin changes during radiation therapy. Let's listen to what Dr. Ross has to say about caring for your skin on the part of your body being treated.
Some people find their skin gets sore, dry, or a little itchy during radiation therapy. Take these 3 steps to help your skin feel better during treatment. First, treat your skin gently. Talk with your doctor before using any products on your skin, such as lotions, creams, or deodorants. Ask about the best time to use skin products. Some should not be used for several hours before treatment. Also, don't use heating pads, ice packs, or bandages in the area where you are getting treated, and stay away from tanning beds. Second, protect your skin. Pick comfortable clothes. It may help to wear clothes that are loose and made of cotton. Going outside, make sure your clothing covers your skin on the part of your body being treated. If your skin hurts in the area being treated, let your doctor know. You might have what is called a moist reaction. Most often this happens in areas where the skin folds, such as behind the ear or under the breast. It can lead to an infection if not treated. Finally, keep showers and baths short. Always use warm, not hot water. You'll want to use soap without any fragrance, so look for the word unscented on the label.
Let's review Dr. Ross's hints to help you avoid mild skin problems. Talk with your doctor or nurse about what skin products you can use. Avoid using heating pads, ice packs, or bandages in the area where you are getting radiation therapy. Wear loose clothing made of cotton and make sure to cover the skin in your treatment area when you go outside. Watch out for a moist reaction, which may happen if your skin stays damp or wet in areas where the skin folds. Call your doctor or nurse if you notice any changes. Whether bathing or showering, make sure the water is warm, not hot, and use unscented soap. Lastly, talk with your doctor or nurse to learn more about how to best care for your skin during treatment.
So I think you listened to the audio. We're back. Right, now we're going back to where we started. Right, now to learn more about flu-like symptoms, we go to the next. Right, learn more about flu-like symptoms caused by cancer treatment. Right, flu-like symptoms caused by cancer treatment. Flu-like symptoms, also called flu-like syndrome, are a group of related side effects that may be caused by cancer treatments such as chemotherapy and immunotherapy. If flu-like symptoms are severe, you may be advised to seek immediate medical attention. Some people who receive higher doses of treatment or more than one treatment at a time may have more severe flu-like treatments. As you see here, you learn about the flu-like symptoms here in this picture. That's a patient there. you may have during treatment for cancer. Learn about flu-like symptoms during the treatment and know when to call your doctor or seek urgent medical care. This photo is done by iStock, credit iStock. And now, when you talk to your doctor, so you know what flu-like symptoms to expect based on your treatment. Some types of chemotherapy can cause flu-like symptoms within a few hours after treatment. These symptoms generally last for 2 to 3 days. So before we proceed on, okay, let's see if there's anything else you need reference to. Right, okay, so let's see the chemotherapy. Chemotherapy to treat cancer. Chemotherapy, also called chemo, is a type of cancer treatment that uses drugs to kill cancer cells. On this page, we have how chemotherapy works against cancer, which types of cancer does chemotherapy treat, how chemotherapy is used with other cancer treatments. Chemotherapy can cause side effects, how much chemotherapy costs, what to expect when receiving chemotherapy, special diet needs while on chemotherapy, working during chemotherapy. Right? So how chemotherapy works against cancer. Chemotherapy works by stopping or slowing the growth of cancer cells, which grow and divide quickly. Chemotherapy is used for 2 reasons. To treat cancer. Chemotherapy can be used to cure cancer, lessen the chance it will return, or stop or slow its growth, ease cancer symptoms. Chemotherapy can be used to shrink tumors that are causing pain and other problems. Which types of cancer does chemotherapy treat? Chemotherapy is used to treat many types of cancer. For some people, chemotherapy may be the only treatment you receive, but most often you will have chemotherapy with other cancer treatments. The types of treatment that you need depend on the type of cancer you have, if it has spread and where, and if you have any other health problems. To learn more about treatments for your cancer, see the PD cancer treatment summaries for adult and childhood cancers. How chemotherapy is used with other cancer treatments. When used with other treatments, chemotherapy can make a tumor smaller before surgery, or radiation therapy called neoadjuvant chemotherapy destroy cancer cells that may remain after surgery, or radiation therapy called adjuvant chemotherapy help other treatments work better, kill cancer cells that have returned or spread to other parts of your body. Chemotherapy can cause side effects. Chemotherapy not only kills fast-growing cancer cells, but also kills or slows the growth of healthy cells that grow and divide quickly. Examples are cells that line your mouth and intestines and those that cause your hair to grow. Damages to healthy cells may cause side effects such as mouth sores, nausea, and hair loss. Side effects often get better or go away after you have finished chemotherapy. The most common side effect is fatigue, which is feeling exhausted and worn out. You can prepare for fatigue by asking someone to drive you to and from chemotherapy, planning time to rest on the day of and day after chemotherapy, asking for help with meals and childcare on the day of and at least 1 day after chemotherapy. There are many ways you can help manage chemotherapy side effects. For more information, see the section on side effects. Side effects of cancer treatment. Cancer treatment and cancer can cause side effects. Side effects are problems that occur when treatment affects healthy tissues, organs. Speak up about any problems you have. Your healthcare team can take a treat and or talk with you about ways to reduce these side effects so you feel better. Learn about steps you can take to prevent or manage the side effects listed below. Anemia, appetite loss, bleeding and bruising, thrombocytopenia, constipation, delirium, diarrhea, edema or swelling, fatigue, fertility issues in boys and men, fertility issues in girls and women, flu-like symptoms, hair loss, alopecia, infection, neutropenia, lymphedema, memory or concentration problems, mouth and throat problems, nausea and vomiting, nerve problems, peripheral neuropathy, organ-related inflammation, immunotherapy, pain, sexual health issues in men, sexual health issues in women, skin and nail changes, sleep problems, and urinary and bladder problems. Keep in mind that side effects from person to person amongst people receiving the same type of treatment. Should we go back to where we came from? Right, and how much chemotherapy costs? The cost of therapy depends on the type and dose of chemotherapy used, how long and how often chemotherapy is given, whether you get chemotherapy at home or in a clinic or office or during a hospital stay, the part of the country where you live. Talk with your health insurance company about what services it will pay for insurance plans, pay for chemotherapy. To learn more, talk with business office where you go for treatment. If you need financial assistance, you go to organizations that may help. To find such organizations, go to the National Cancer Institute database. Organizations that offer support services and search for financial assistance or call toll-free 1-800-4-CANCER, 1-800-422-6237 to ask for information on organizations that may help. What to expect when receiving chemotherapy? So chemotherapy is given in many ways, being oral. It comes in pills, capsules, liquids that you swallow. Intravenous IV goes directly to a vein. Injection given by a shot in a muscle in your arm, thigh, or hip, or right under the skin in a fatty part of your arm, leg, or belly. Intrathecal injected into the space between the layers of tissue that cover the brain and spinal cord. Intraperitoneal IP goes directly into the peritoneal cavity, which is the area in your body that contains organs such as your intestine, stomach, and liver. Intraarterial IA injected directly into the artery that leads to the cancer. Topical comes in a cream that you rub onto your nose. All the methods mentioned above, chemotherapy is most often given with an IV through a thin needle. It is placed in a vein on your hand or lower arm. Your nurse will put the needle in at the start of each treatment and remove it when treatment is over. IV chemotherapy may also be given through catheters or ports, sometimes with the help of a pump. You use a catheter, which is a thin, soft tube. A doctor or nurse places one end of the catheter in a large vein, often in your chest area. The other end of the catheter stays outside your body. Most catheters stay in place until you have finished your chemotherapy treatment. Catheters can also be used to give you other drugs and to draw blood. Be sure to watch for signs of infection around your catheter. See the section about infection for more information. Port is also used. A pump is used. A port is a small round disc that is placed under your skin. During minor surgery, a surgeon puts it in place before you begin your course of treatment. It remains there until you have finished. A catheter connects the port to a large vein, most often in your chest. Your nurse can insert a needle into your port to give you chemotherapy or draw blood. This needle can be left in place for chemotherapy treatments that are given for longer than 1 day. Be sure to watch for signs of infection around your port. See the section about infection for more information. Pumps are often attached to catheters or ports. They control how much and how fast chemotherapy goes into a catheter or port, allowing you to receive your chemotherapy outside of the hospital. Pumps can be internal or external. External pumps remain outside your body. Internal pumps are placed under your skin during surgery. And how your doctor decides what chemotherapy drugs are given to you. We'll come to that later. Let's check on infection, on all these aspects that may have come around the port or the catheter. Infection and neutropenia during cancer treatment. An infection is the invasion and growth of germs in the body, such as bacteria, virus, yeast, the fungi. An infection can begin anywhere in the body, may spread throughout the body, and can cause one or more of these signs. Fever of 100.5 degrees Fahrenheit or higher, chills, cough, or sore throat, diarrhea, ear pain, headache, or sinus pain, or a stiff or sore neck, skin rash, sores or white coating in your mouth or your tongue, swelling or redness, especially where a catheter enters your body, urine that is bloody or cloudy, or pain where you urinate. You can call your healthcare team to check on this, and be sure to talk with your doctor or nurse before taking medicines. Even aspirin, acetaminophen such as Tylenol, or ibuprofen such as Advil For fever, these medicines can lower a fever but may also mask or hide signs of a more serious problem. So inform your task team, your team, medical team. Some types of cancer and treatments, such as chemotherapy, may increase your risk of infection. This is because they lower the number of white blood cells, the cells that help your body to fight infection. During chemotherapy, there will be times in your treatment cycle when the number of white blood cells, called neutrophils, is particularly low and you are at risk of infection. Stress, poor nutrition, and not enough sleep can cause also weaken your system, making infection more likely. You will have blood tests to check for neutropenia. That is a condition in which there is a lower number of neutrophils. Medicines may sometimes be given to help prevent infection or to lower the risk of increase the number of red blood, number of white cells. Ways to prevent infection: wash your hands often and well, stay extra clean, avoid germs. For food safety for people with cancer, for essentially food safety for people with cancer, please watch this video, right? By National Cancer Institute.
Some people with cancer have an increased risk of foodborne illness. Here are 8 tips from the National Cancer Institute to keep in mind when preparing food. 1. Wash your hands, knives, and countertops before and after preparing food. 2. Use separate cutting boards and knives for meats and produce. 3. Wash all raw fruits and vegetables before eating them. 4. Thaw meats and fish in the refrigerator or microwave. Do not thaw at room temperature. 5. Don't consume raw fish or meat or unroasted nuts. 6. Don't consume unpasteurized juices, eggs, or dairy products. 7. Use a thermometer to cook meat and eggs to safe temperatures. 8. Don't eat food sitting out for more than 2 hours. Put leftovers in the fridge right away and eat them within 3 days. To learn more, go to cancer.gov/nutrition.
So that was a short video. I hope you got the points right. Some cancer treatments make it easy for you to get sick from contaminated food. So 8 tips for food safety during cancer treatment can help you properly handle and prepare food to reduce your risk of foodborne illnesses. Right, we go to the next kind of therapy. Some types of immunotherapy increase the body's natural immune response, which can cause mild to severe flu-like symptoms. These symptoms often peak shortly after treatment and become less severe over time. Immunotherapy treatments such as CAR, T-cell therapy, and some monoclonal antibodies may cause cytokine release syndrome, CRS, a condition that can lead to severe flu-like symptoms, as well as a rash, rapid heartbeat, low blood pressure, and trouble breathing. Doctors may refer to severe cases of CRS, cytokine release syndrome, as a cytokine storm. Ask your healthcare team about flu-like symptoms. About all these questions: what signs and symptoms might I have based on the type of cancer treatment I'm receiving? And should I call you about what symptoms should I call you about? What can be managed at home, right? And many flu-like symptoms you should call the team about: appetite loss, body aches, muscle joint pain, chills, diarrhea, fatigue, fever of 100.5, 38 degrees centigrade or higher, headache, and nausea and vomiting. What ways to manage flu-like symptoms during cancer treatment? Just going back to the monoclonal antibodies. These can cause mild to severe allergic reactions while you are receiving the drug. In a rare case, the reaction is severe enough to cause death. Some monoclonal antibodies can also cause capillary leak syndrome. This syndrome causes fluid and proteins to leak out of tiny blood vessels and flow into surrounding tissues, resulting in dangerously low blood pressure. Capillary leak syndrome may lead to multiple organ failure and shock. So cytokine release syndrome. can sometimes occur with monoclonal antibodies, but it is often mild. Cytokines are immune substances that have many different functions in the body, and a sudden increase in their levels can cause fever, nausea, headache, rash, rapid heartbeat, low blood pressure, and trouble breathing. How monoclonal antibodies treat cancer? I think we did have a video on that. We saw that. And while we go back to the basics, the initials, right? The types of cancer, genes that cause cancer, right? And tumor suppressor genes. And we were talking on these proto-oncogenes, tumor suppressor genes, and DNA repair genes. So while we read on them, we did finish on proto-oncogenes, and tumor suppressor genes also involved in controlling cell growth and division. Cells with certain alterations in tumor suppressor genes may divide in uncontrolled manner. And DNA repair genes are involved in fixing damaged DNA. Cells with mutations in these genes tend to develop additional mutations in other genes and changes in their chromosomes, such as duplications and deletions. Okay, so what was that we did? New federal approval further is the role of genomics in cancer care, right? So a new FDA approval furthers the role of genomics in cancer care. A recent drug approval by the FDA administration makes another milestone in the treatment of cancer. The action by FDA expands the growing list of approved uses for the immune checkpoint inhibitor pembrolizumab, or Keytruda. In this case, it is now approved to treat some adults or children with advanced cancer, regardless of the type of cancer they have, if the patient's tumor has a larger number of genetic mutations, also called a tumor mutational burden, high TMBH cancer. So the illustration here shows, this is the illustration, right? Right here, the cancer cells that are TMBH tend to produce a large number of mutant proteins on their surface, known as neoantigens. These proteins can draw the immune system's attention. The credit goes to adapted from An Oncology, January 2019, DOI 10.109.3//MDY495.cc by 4.0. That's the credit section. Credits to them for giving us this lecture. And the next part of it is, while treatment is under process. And in this case, it is now approved that to treat some cancer, whether children or adults, advanced regardless of the type. If it's advanced, you can get in to treat them with patients having a large number of genetic mutations, also called tumor mutational burden. It's high TMBH cancer. So because this is what is known as accelerated approval, this new indication for pembrolizumab must be confirmed in additional studies. There are also a number of factors for oncologists to consider when deciding whether this treatment is a good option for patients. We'll go to these issues later. But from a broader perspective, this new approval represents continued march towards the use of genomics to guide cancer treatment, including for children with cancer. It reinforces the idea that as a routine matter, oncologists should be discussing tumor genomic testing or biomarker testing with their patients with advanced cancer, in particular those for whom there are no effective standard of care treatments. This applies to testing not only for biomarkers like TMB that might predict response to immunotherapies, but also for genetic biomarkers that identify those who might benefit for a specific targeted cancer treatment. This type of biomarker testing has helped patients with many types of cancers, even hard to treat cancers such as brain and pancreatic, by identifying therapies that, by more might be more effective and less toxic for them. But it's important to know that biomarker testing has important limitations, and clearly there are many patients who do not benefit from this testing. This new approval for pembrolizumab marks the fourth time that FDA has approved a drug to be used in a tissue-agnostic manner, that is, for any cancer type based solely on the results of biomarker testing. Given that there are now many approved cancer therapies, those that require less genomic biomarker testing via what are known as companion diagnostics, it is believed that genomic biomarker testing should be strongly considered for all patients with advanced cancers for which no known effective treatments are currently existing. Given this increasing role of genomic biomarker testing in cancer care, it is important to note that many patients do not benefit from molecularly targeted treatments because they are never offered that testing. For example, a recent review in lung cancer where genomic testing is particularly critical for selecting the most appropriate treatments found that 10% to 40% of patients are not being tested for molecular alterations that predict response to FDA-approved therapies, even though such testing is recommended by clinical guidelines. Let's just have a look at that. Biomarker testing for patients with advanced non-small cell lung cancer, real-world issues, and tough choices. Well, the abstract reads, over the last decade, the treatment of patients with advanced non-small cell lung cancer, NSCLC, has become reliant on tissue and/or blood biomarkers to help guide treatment decisions. There are now multiple biomarker-defined patient subgroups with evidence showing that treatment with targeted therapies has superior clinical outcomes when compared with traditional cytotoxic chemotherapy. However, rapid change in the field of precision oncology brings with it the challenge of translating recommendations into clinical practice. In this review, we discuss the major guidelines recommending biomarker testing in NSCLC as well as the logistical challenges to applying these guidelines to patients with NSCLC both in the United States and worldwide. The techniques commonly used for biomarker testing will be discussed both for tissue and blood-based biomarkers. Finally, we discuss the challenge for interpreting the results of biomarker testing and using these results to guide treatment decisions. So we have articles based on these. We'll come back to them later. And now, I've written that this lack of biomarker testing, which can lead to the use of treatments with the potential to markedly improve how long patients live, is concerning. At NCI, it's being pondered over about the possibility that less genomic biomarkers testing in patients from underserved populations could further exacerbate existing cancer-related health disparities. Learn about cancer and tumor mutational burden. That's about the TMB burden. It's not a guarantee that pembrolizumab will be effective, but it is an opportunity based on a robust evidence base that was developed in part by NCI-supported research and investigators. It is also important to know that this is not the first tissue-agnostic FDA approval for pembrolizumab. In May 27, it was approved to treat any cancer that has specific generic alterations that affect a cell's ability to repair damaged DNA, known as microsatellite instability high MSI-H tumors. Microsatellite instability high MSI-H and TMB-H are related, with most MSI-H tumors also showing increased TMB-H. The converse, however, is not true. That is, many TMB-H tumors are not MSI-H. Moreover, MSI status does not necessarily need to be established through extensive tumor genomic testing, whereas TMB-H status generally does. So having a drug approval based on TMB is important because it is more common in tumors than MSI-H. The time now is 6 o'clock, local time, Indian Standard Time. And continuing with the lecture. we see that moreover MSI status does not necessarily need to be established through extensive tumor genome testing, whereas TMB status generally does. So having a drug approval based on TMB is important because it is more common in tumors than MSIH, and thus should promote for greater adoption for tumor genomic testing. Cancer cells that are MSIH and TMBH tend to produce a large number of mutant proteins and which are then often displayed on the cell surface as neoantigens. Since normal cells do not display such mutant proteins, the production of neoantigens can be a signal that draws the immune system's attention. That in turn can increase the likelihood that treatments like pembrolizumab, which strengthen the anti-tumor immune response, will help immune cells kill those tumors. In the clinical trial on which FDA based this new approval called KEYNOTE-158, nearly 30% of patients with TMB-H tumors had a response to treatment. Meanwhile, they experienced, at least 30% reduction in size of the tumors, including some whose tumors disappeared completely. In contrast, the only 6% patients who are not TMB-H exhibited a response to pembrolizumab, and half of the participants who responded to the treatment, their tumors did not begin to grow again for at least 2 years. So although patients on KEYNOTE-158 were not randomly assigned to an alternative therapy or placebo, these types of sustained treatment response among patients with solid tumors are extremely rare with standard chemotherapies. In addition, most participants on the KEYNOTE-158 had received numerous other therapies and had no remaining treatment options known to be effective against the cancer. That's an important point because FDA's new approval applies only to people with advanced cancer without any standard treatment options. So, in general, tumors in children and young adults with cancers do not have a large number of mutations and are therefore less likely to be TMB-H. But some tumors that arise in children are less likely to be TMB-H, but some tumors that arise in children are TMB-H, and this approval now means that such young patients have a new, potentially meaningful treatment option available to them as well. This is the photo of the NCI director, Dr. Norman E. Sharpless. Credit goes to the National Institutes of Health. Right, and should we just show the photograph once again? Right, okay. And we need to thank all of them for the credits given to us, for the awareness imparted to us through their invaluable notes and lectures. Contribution of genomics research. The role of NCI-supported research is helping to identify TMB as a biomarker of immunotherapy response is particularly gratifying. And for example, all the TMB did not even exist as a concept at that time that the Cancer Genomic Atlas TCGA was launched. Researchers used TCGA data to perform wide-scale analysis of the relationship between tumor mutation numbers and immunotherapy response in the first place. The finding is another example of how building large, high-quality and diverse sets of research data and making them publicly available can yield unexpected insights that lead to meaningful advances in treatment. In addition, NCI has a sustained and successful partnership with Foundation Medicine, the company that developed Foundation 1 CDX, the test used to identify patients with TMB-H tumors. For this approval, NCI-supported researchers made important contributions to the development of the technologies used by this test. And this is an extremely complicated area of research, as expected. Even with the best tests measuring of TMPH and deciding what the measurements means for individual patients, in particular estimating their likelihood of response to immunotherapy is far from straightforward, and additional is there. So there are other aspects where NBA and CI has been working on, and they've been partnering with Friends of Cancer Research on the TMB harmonization project, which is working to standardize how mutational burden is measured in tumors using different technologies and approaches. This project will help to ensure the TMB is used in the most effective manner possible to guide decisions about patient care. And there's good news and more to learn. This new approval is exciting, and it will be and have an immediate impact on patient care. However, it's important to stress that TMB status is just one of the pieces of an information about a tumor. To relate to its relevance to treatment may depend on a number of factors, including patient's physical ability and willingness to tolerate further treatments. In Keynote 158, most patients with PMBH tumors didn't benefit from pembrolizumab, and a small percentage of patients whose tumors had a low TMBH did respond to treatment. This suggests we still have more to learn in order to predict who will respond to immunotherapy drugs. And that being said, let's just go back. All right, and when cancer spreads is the next session, okay? So, of a study. A cancer that has spread from the place where it is first formed to another place in the body is called a metastatic cancer. So the topic before that was just had done types of genes that cause cancer. I think we just read about that, right? Now, the process by which a cancer cell spreads to other parts of the body is called metastasis. Metastatic cancer has the same name and the same type of cancer cells as the original primary cancer. Now, you should remember that on each of these topics on cancer, and likewise in all subjects, wherever there is a reference, I go to those references from them to various. So we go to various layers of study, and then I revert to the basic. So here I'm back at the basic from here. So you need to note that there are specific terminologies, specific procedures, specific drugs, okay, and what kind of drugs, specific certifications by the FDA. Likewise, so many innovative procedures, innovative developments, right? So everything going step by step, so you have your basics and you get to know the latest as well. So please pay attention to every aspect as I teach. So link yourself 1, 2, 3, 4, and you try to reverse back to the square one and study what is it. So we're back to stage the square one where we were studying about the genomic part. Now we're going to the growth of it. So we talk about metastatics. There could be malignancies, there could be benign stage. All that comes in the basics, and then we go to the next. Right? So we slowly advance in the study. So by the time you finish, you would have learned a lot, far better than the stereotype textbook learning. This is a much better way of learning. So you get to know the ground reality plus the basics all at one go, right? So be attentive and you should be just fine. And you can ace any exam. So under a microscope, metastatic cancer cells generally look at the same as cells of the original cancer. Moreover, metastatic cancer cells and cells of the original cancer usually have some molecular features in common, such as the presence of the specific chromosome changes. In some cases, treatment may help prolong the lives of people with metastatic cancer. In other cases, the primary goal of treatment for metastatic cancer is to control the growth of other cases. The primary goal of treatment for metastatic cancer is to control the growth of the cancer or to relieve the symptoms it is causing. Metastatic tumors can cause severe damage to how the body functions, and most people who die of cancer die of metastatic disease. Tissue changes that are not cancer. Not every change in the body's tissue is cancer. This is also something you should necessarily know about. Some tissue changes may develop into cancer if they are not treated. However, here are some examples of tissue changes that are not cancer, but in some cases are monitored because they could become cancer. One would be hyperplasia, occurs when cells within a tissue multiply faster than normal and extra cells build up. However, the cells and the way the tissue is organized still look normal under a microscope. Hyperplasia can be caused by several factors or conditions, including chronic irritation. Dysplasia is a more advanced condition than hyperplasia. In dysplasia, there is also a buildup of extra cells, but the cells look abnormal and there are changes in how the tissue is organized. In general, the more abnormal the cells and tissue look, the greater the chances that cancer will form. Sometimes the dysplasia may need to be monitored or treated, but others do not. An example of dysplasia is an abnormal mole called a dysplastic nevus that forms on the skin. A dysplastic nevus can turn around into melanoma, although most do not. Carcinoma in situ is an even more advanced condition. Although it is sometimes called stage 0 cancer, it is not cancer because abnormal cells do not invade nearby